The floor is open for discussions. We have about 20 minutes, so I invite the speakers either to come up or just if you want to address questions to them one after the other. Until 10:30, no? It's 10:10, I guess we have less time. Question for each, if anyone has from the audience. I might start by asking Professor Lennon. Well, you gave a study on 65, 70, and how about if we start at 50? How good is going to be the positive or the negative predictive value? And then which tests are we going to use? All the tests are similar, cells, mRNA, microRNAs, are they universal, or each lab is going to create one of its own?
You asked some wonderful questions to which I don't have the answer. So I think that if I start with your second question first, I think there's four major liquid biopsy tests that are currently are out there. And what we really need, I think question number one is, do they work? Can you detect cancer? Now we can say yes. Two, can you detect early cancer, which is all that really matters? And the answer is yes. Is it perfect? Is it going to replace colonoscopy or other things? The answer is no. There's going to need to be, this is not ready for, in my opinion, real-time and in clinical practice. I think we need prospective randomized trials to confirm if we're going to implement it truly. We need high-quality evidence. And then after that, we need a head-to-head study. So that study, the NIH has put that together. If the companies who bought the technology agree, that study will start next year in 2024 and can help answer that question. And your first question is, there's multiple people are looking at different things. So Delphi have got fragmentomics. There's Exact Sciences are using that combination that I showed you. The Grail Gallieri test looks at methylation. There's multiple different ones. What we really need is a head-to-head comparison to answer that question.
Thank you.
Question for Professor Bandari, please. Thank you very much for your presentation. I have a question about the modalities that we're using in diagnosing the gastric metaplasia. Will CLE help you with the patient on the table? I know that you're using MBI and LCI. With the patient on the table, will CLE optical biopsy help you in diagnosing such a cases?
If I understand your question right, you're saying whether advanced imaging like BLI, NBI, can optical that help biopsy. Us detect intestinal metaplasia and also help us make a decision?
Yeah.
Is that right?
As an optical biopsy, yeah.
Yes, absolutely. Intestinal metaplasia is visible with white light. The modern endoscope, all with white light you can see. But when you use BLI or NBI or OE scan, you can definitely see intestinal metaplasia. Now, whether you want to stay till there and say, I found patient has got intestinal metaplasia, or with the current standard is, then do targeted biopsy. So what I'm not suggesting is just look at with NBI, BLI, and say patient has got IM, call for surveillance. Now, I'm saying is use these technologies to target your biopsy, because the recommendation is that we don't do surveillance for distal intestinal metaplasia. If it's only in the antrum, we don't do surveillance for them because risk is very low. So we need to find in the distal stomach and in the proximal stomach. So then there's a pan-atrophic gastritis, diffuse IM. Those are the patients who benefit from surveillance. So use the technology to target a biopsy, prove there is a pan-IM, and then we follow them up.
Thank you.
Yeah.
Thank you. Thank you, Pradeep. This question is actually for all of you. And I really like your talk, Professor Rahman, Professor Bandari, regarding gastric metaplasia and early cancer. What advice, we have a lot of fellows in the audience, so what advice do you have for the fellows on how to start learning about early detection, doing a good quality gastroscopy? What are some websites you suggest? Anyway.
If we go Anne-Marie's way, there is no need to do endoscopy. So I'll let Anne-Marie answer this question. I think, to me, first thing is for gastroscopy, what do you need? For any good quality endoscopy, what we need is a clean field. So for colonoscopy, you need very good quality bowel prep. Most endoscopists, they feel we are advanced endoscopists. I'm not bothered about bowel prep. Well, disasters will happen. You will eat when you get a complication and a bleeding with poor bowel prep, disaster. Patient needs surgery. Perforation with poor bowel prep, they need surgery. Okay, same principle for gastroscopy. We give drink. How many people in the audience here, including the faculty, before gastroscopy, do you give a pre-gastroscopy drink? Anybody? No. Well, that's basic. Forget about the modern technology and AI and BLI. You need to give a drink to the patient to get rid of that mucus, the bubble. So in our unit, standard policy, you come for gastroscopy, you get 100 ml of water, 5 ml of N-acetylcysteine, which is the paracetamol overdose drug, Pavlax. 5 ml of that, it stinks like eggs, but that's what you put in there. And 5 drops of simethicone, you know, the bubble busting agent. Yeah. Have a drink, 5 minutes before the procedure, bubbles disappear, mucus disappears, you go in, you suck, everything is out, stomach looks clean. First thing, okay? Buscopan, adequate sedation, so the patient is not retching and coughing, and you're just not going in and out. And then inflate and deflate. Look at the high-risk stations. Your incisura is a very high-risk station. Antrum is high-risk station, and cardia. So very good quality retroflexion to look at cardia, incisura, and just overall good quality assessment.
Thank you.
One last question to Professor Rahmi, and then I guess we're going to have to close. In a country where the majority of us will do an EMR instead of an ESD, how good are we in treating the tumors or the SM1, SM2 T tumors that you are talking about?
Yes, this is a really good question, an important question, because of course we have to perform what we know and when we was trained for. And then if you know how to perform ESD, I recommend strongly to make an ESD if you have a big lesion, because you will have as you see, the pathological report is really important, and if you pass with a snare through the cancer, it will be really difficult to have this kind of factors. But if you have only the EMR technique in your unit, and if you have LST, granular, homogeneous lesion, please use it, and you don't have to refer the patient to the surgeon. And what we discussed about the characterization, and just to try to know if there is a deep cancer or superficial cancer, please use the virtual chromoendoscopy, use the magnification or other staining strategy, just to try to avoid to over-treated surgically some patients.
Please.
So just one last comment. I just want to be clear on the liquid biopsies. They are not replacing endoscopy. What they're actually doing is diagnosing patients who need to go, and I think they're very complementary. So you gave that wonderful case of what do you do with you resect the cancer, you don't know, do you need to send the patient to surgery or not? I would say do a liquid biopsy. If it's positive, the patient needs surgery.
Just one comment on this. We're going to still do colonoscopy because you're detecting early cancers. We're not preventing. So we're not doing polypectomies with liquid biopsies. So we're going to continue doing colonoscopy for the polyps, I guess.
Absolutely. I think it's not there. It's complementary. It's absolutely not replacing.
Thank you very much, everyone.